Good afternoon, good morning, good evening, wherever you are. Welcome to this joint webinar between ESICM and the Indian Society of Critical Care Medicine that we cherish very much. I'm delighted to co-chair this webinar with Professor Sheila Miyatra, and it's going to be focused on acute respiratory distress syndrome. You all know that the European Society has recently released very important guidelines showing how much we target to improve the care at the bedside. This collaboration with our colleagues and friends from India is very important to us. Not only we share research and training collaborations, but also a very long-standing friendship, and we like to get together. As you know, this year for the third time, we would go to India for EuroAsia, and I would like to thank Professor Miyatra for giving us so much opportunity and so much attention. Sheila, good afternoon. I hope you are well.
Hello, everyone. Thank you. Thank you for that great introduction. And hello, everyone, and welcome to this second joint webinar between ISCCM and ESICM. I'm especially grateful to Professor Azoulay for our continued, webinars and collaboration with the ESICM, which is really important for us. And today we have selected a very relevant and a very important topic. As has already been alluded to, these are the new guidelines that have been jointly published in the journal, and there's a lot of new content, and we have three excellent speakers who are all doyens in the field who are going to take us through three very interesting topics. So without any delay, I'll start with the first presentation. The first speaker is from India. He's Dr. Sumit Ray, who is the medical director and the head of the intensive care unit at the Holy Family Hospital in New Delhi. And he's also the secretary of the Indian College of Critical Care Medicine. And he's going to be speaking about from Berlin to the new global, the new definitions in ARDS. Over to you, Dr. Sumit Ray.
Thank you, Sheila. Thank you, Dr. Azoulay. And thank you for having me here on the ESICM, ISCCM webinar. And good afternoon, everyone. Good afternoon, good evening, depending on what time zones you are in. So as Sheila told you, I would be speaking from Berlin to global, the new definition for ARDS. The first question that arises whenever we have a new definition is, why do we need it? And to answer that, I had to go through quite a few articles. The two articles that really helped me was one on the left by Dr. Raniere and Dr. Slutsky, and on the right, this one both published in AJRCCM by Dr. Narges et al., and in which Sheila Miyatra is also there, and she who's the moderator. So obviously we need a formal definition of ARDS, and we have had it for a while. And because the need for a definition, formal definition, is to allow us to include similar patients for therapeutic options, for prognostic information, for our research modalities, what are the research interventions which would be effective in the in these subset of patients. But the problem, the major challenge with ARDS is that it lacks a gold standard within quotes to define it and to understand what the construct of ARDS is. How does it express itself? And whenever we have a difficulty, when we don't have a gold standard, we have a syndromic approach, which is also similar to what the social scientists call a construct. A construct, basically, or a syndromic definition, has been there with us for a long time for disease processes. Basically, it is what aims to identify groups of patients with shared signs and symptoms in an objective and reproducible manner. And it's interesting that we are taking terms from social science into internal medicine. I see that also in the sepsis definition, because social science has taken definitions, research from us. A couple of years back, the Nobel Prize for Economics was won by Esther Duflo and Abhijit Banerjee, which they based on their study by reusing randomized controlled trials in economics. And so it's time that we also gathered and gained cross-dimensional knowledge from them. So the whole construct of, I think, ARDS, how it is defined, has been relevant to us for the last 30 years or so, if not earlier. I would like to go back to even before the Berlin definition, the American European Consensus Conference definition, the AECC definition. As you can see, the construct that ARDS is a syndrome of inflammation with increased permeability that is associated with a constellation of clinical, radiological, and physiological abnormalities, which is not primarily explained by a left heart failure or pulmonary capillary hypertension. And in this definition also, they gave the predisposing factors that would lead to it, like sepsis, trauma, etc. And just to remind ourselves, they said it is an acute onset. They didn't give a timeline, bilateral chest radiograph. So the construct of ARDS has been fairly solid with us for a while, and we'll see how the new definition looks at it, or has it changed it. And but also just to remind you, it was regardless of PEEP, this definition of ALI, ARDS that they had was regardless of PEEP, and they also looked at the pulmonary capillary wedge pressure. So those who defined the Berlin definition in about 18 years later in 2012, there were certain limitations of the AECC definition, and that was that one, there was no definition of the time period. So they put in about a week, as we all know. And the PF ratio, the ALI criteria was a little problematic. It was confusing. So they made it all ARDS, minimal, moderate and severe. And the chest radiographs, they gave some more examples, created examples of how to define the chest, how to look at the chest radiograph, because there was inter-observer variability. The reliability was poor. And as I said, they added a PEEP across all the ARDS criteria, so that there was no inconsistency between the PF ratio and the use of PEEP. And the wedge pressure criteria was removed, and there was more emphasis on the explanation of that, the fact that the hydrostatic edema was not the primary cause of the respiratory failure, and they gave vignettes to explain that, and because also the wedge pressure and ARDS could coexist, and there was inter-observer reliability was poor between wedge pressure and the clinical assessments of left atrial hypertension. And they put in the risk factors, though it has been mentioned in the AECC, but it was not, included clearly in the definition which they had. So all of you know the Berlin definition, the acuteness of it, the 1 week time period, the bilateral opacities, the respiratory failure, the mild, moderate, and severe categories of ARDS, which has PEEP in it in the definition itself. Now the question comes, so why did we need this definition? I think the main focus of the guideline authors was that to be more inclusive, because the LungSafe study showed that almost 20% of patients with severe ARDS and up to 50% of patients with mild ARDS were not recognized as having ARDS. So they included patients on HFNO, and we'll look at the evidence for or against it. They were also focused a lot on the resource-limited settings where an SF ratio, so SpO2 to FiO2 ratio, could be used in place of a PF ratio. They looked at lung ultrasound to be added or supplant chest X-ray where chest X-rays were not available, and remove the PEEP criteria again in those subsets of patients in the resource-limited settings. And hopefully to improve reliability and validity too in the process. So the new global definition had a bevy of stars of critical care medicine, and particularly who have worked on ARDS, 32 authors, if I'm not wrong. And as I said, the clinical construct and the conceptual model, they did not think that it was necessary to change it much from the Berlin definition, because I think, as I said, there has been a pretty solid understanding of what we believe ARDS is, and the face validity, as they call it, of ARDS. So they looked at very minor revisions, the focus being probably the influence of, as you can see, the clinical presentation is influenced by the medical management, as they said, the position, the sedation, the paralysis, the positive end expiratory pressure, and the fluid balance. All these elements affect the PF ratio, etc., and the management of ARDS and the definition of ARDS. Also, one important factor in the definition of ARDS is the origin of the edema. And as on top, as you can see, is the origin of edema as defined by the Berlin definition. This definition, the new definition, global definition as it's called, gave a more detailed understanding of it, or an explanation of it. That is, what they said is pulmonary edema is not exclusively or primarily attributable to cardiogenic pulmonary edema or fluid overload, and the hypoxemia is not not primarily attributable to atelectasis, but ARDS can be present even in the presence of these factors, if the predisposing risk factors are there for ARDS, even with cardiogenic pulmonary edema. So coming to the global definition, so it's the timing of acute onset, worsening within 1 week, acute hypoxemic respiratory failure, with predisposing factors, as we spoke about, and new and worsening symptoms. The risk factors have been included, the origin of edema, as we discussed, and in the imaging, the bilateral opacities on the X-ray or CT scan. Also, the B lines and consolidation on the lung ultrasound would be included in particularly resource-limited settings. And they made 3 categories for defining ARDS: the non-intubated ARDS, the intubated ARDS, and the resource-limited setting ARDS. So in the non-intubated ARDS, the PF ratio remained the same to define ARDS less than 300, but they added the SF ratio, which is less than 315, if the SpO2 was less than 97% for patients on HFNO with a flow of more than 30 liters per minute, or patients on NIV CPAP with at least 5 centimeters of water of end expiratory pressure. Intubated ARDS, the categories remained the same. For the PF ratio, they added different SF ratios. I can see here. I'm not going to go into the details of that exact numbers. And then there was the resource-limited settings where they could define ARDS with the clinical construct that we had developed for what ARDS is, without the need for PEEP or an oxygen flow rate. And we'll look at all this and the evidence behind that. So this is how it looks on the paper. And so what they also wrote about is the rationale for updating the criteria that was there in the Berlin definition. And for the acute setting of 1 week, they considered a more longer setting, for the insult, because some patients had a more indolent course, like COVID-19 patients. But they thought that the inclusion of patients with HFNO will capture patients which had more indolent courses. But for me, the question is, in resource-limited settings, when there is no HFNC, how would they get captured is a question that remains unanswered. Chest radiograph and computed tomography may not be available in some clinical settings. Thus, ultrasound may be used to identify bilateral loss of lung aeration, as long as the operator is well trained in the use of ultrasound. And that is going to be a catch there, and we'll talk about that a little later. The SF ratio versus as a surrogate for PF ratio. And if the saturation was less than 97, we looked at that. That was part of the definition. They included, because SF ratio is more easily available where ABGs are not available. The use of HFNO, there is an increased use of HFNO since the Florali trial, and also in COVID. So they put the new category of non-intubated ARDS with HFNO at 30 liters per minute. And as I said, in resource-limited settings, where there were no mechanical ventilators, there would be no need for a PF ratio, only an SF ratio would do without PEEP and HFNO. So this was actually this edition was exactly taking into consideration the Kigali modification of the Berlin definition. As you can see, the same points are there. But remember that Kigali modification was done on the basis of a study which was at one hospital in Rwanda. Okay, so does it fulfill the global context or not? We'll have to take a look at that. So what is the evidence and the concerns with the SF ratio versus the PF ratio? There's enough evidence to suggest that the SF ratio, the SpO2 FiO2 ratio, correlates pretty well with the PF ratio in most settings. But recent studies have shown concern about the racial bias in pulse oximetry, particularly since the 2020s, and the guidelines. The definition committee also considered that and said that the recent data suggests that occult hypoxemia occurs 4 times more frequently among patients who identify as Black as compared to white, and that racial discrepancies in the accuracy of pulse oximetry contribute to the care disparities. I think the care disparities are not only because of pulse oximetry, but because of the socioeconomic conditions that are there too. But pulse oximetry adds to it. So we have to, look at it closely and do more research in the future to look how they perform. Now, the rationale for a HFNO at 30 liters per minute in the new definition, we all know that the positive airway pressure can be generated with high flow nasal cannula at high flows. It increases the end expiratory lung volume, reduces the diaphragmatic loading, and lowers inspiratory work and work of breathing, particularly on high flows. This is a physiological study which was published in AJRCCM, HFNO versus at 40 liters per minute versus face masks. And they looked at the inspiratory effort and work of breathing by the esophageal pressure swings. The delta P and the electrical impedance tomography looked at the lung volume, changes in lung volumes and ventilation homogeneity. And HFNC proved that it not only improved oxygenation but lowered respiratory rate, decreased the work of breathing, improved the end expiratory lung volume, even if it did not generate very high peeps. And it improved the dynamic lung compliance, and also ventilation distribution was more homogeneous. So there is a rationale for HFNC probably, and particularly, as I said, the use of HFNC post-Florali trial has increased. And in COVID, the use showed the benefit, certain amount of benefit in mild ARDS with COVID. But all these studies showed that the HFNC flow rates in all these studies were between 40 to 60 liters. So the rationale for having a 30-liter, criteria for the definition is a little worrying, because most of those 30-liter trials have been done on healthy volunteers. And in disease processes, most of the studies have been above 40 liters per minute of HFNO. The other concern was HFNO would include too many patients. There could be a false positivity. And this is a study by Marco Ranieri and Dr. Antonelli is here too, who was part of this trial. And they analyzed COVID patients with PF ratios of less than 300 who were treated with HFNO or NIV with a PEEP of more than 5, and who transitioned to either invasive ventilation. Either of these groups who transitioned to invasive ventilation. And as you can see, almost 60% in HFNO and 53% in NIV transition to invasive ventilation. And they looked at, do these patients continue to have a PF ratio less than 300 after intubation and positive pressure ventilation, invasive ventilation. And they found that nearly 93% of HFNO patients and 96% of NIV patients continue to have a PF ratio of less than 300. So false positives were very small, and even when post-invasive ventilation, and the mortality over both the groups were similar. Now, the use of lung ultrasound for prediction of ARDS. So I'm not going to go into the details of the study, but just this is a very good study which was published in AJRCCM. Again, they looked at lung ultrasound of patients who were intubated after 48 hours of intubation. Who had been intubated in the last 48 hours. And they looked at the A, B, and C patterns, presence of B lines, etc., and they scored them. And then they had an expert panel of 3 people who looked at and defined it as high possibility of ARDS and a low possibility of ARDS. And then there were people looking at the X-rays additional at it. And the derivation cohort showed an AORC curve of about 0.90 for diagnosing ARDS, and the validation cohorts showed about 0.80. But the worry about this was, and this is brought out very well by Dr. Lauren Baer, in the editorial on this, that the low cutoff score to maximize sensitivity was 8 and the high cutoff score was 27. But half the patients fell between this score, and so we don't know how to define those. Where would they fall? And also the generalizability of this study, because this was done mostly in pulmonary ARDS. So in extrapulmonary ARDS, how they would be able to define ARDS is a difficult one. And intra and inter-observer reliability between ultrasound observers were done only in 12 patients as a retrospective analysis. And this is the main concern. And this definition, they sent it out to many of the critical care groups. And this is not the response of the groups, but individuals in the group, and about 190 responses. And of that, almost a third of them, the biggest worry was the use of ultrasound and also the SF ratio. But the biggest worry was ultrasound, and most of the responses came from the American societies. And also the whole idea that if you don't have an X-ray, you get an ultrasound, that probably is not very reliable. It's probably not so relevant in the resource-limited settings, because most of the places which will not have an X-ray will not have an ultrasound, and also not just have it, but also the ability to do a good ultrasound to diagnose ARDS is probably very, very difficult. I visit resource-limited setting every year for a week. I volunteer there, and I find it they are much more competent at looking at X-rays than at ultrasounds. Now, the feasibility, the reliability, and the validity. I'm looking at the Berlin definition at a graphic like this. So the feasibility, yes, the feasibility criteria is there. There is the reliability. We have to check on the reliability, and the predictive validity has to be tested on this because the inclusion has been expanded. There is a face validity, as they say, for this because our concept or our construct for ARDS is pretty strong, and we identify ARDS fairly well as an understanding, but the specifics is what we have to focus on. So just quickly looking at the limitations, and these are brought out by the committee themselves, is that the committee did not use a stringent methodology for reviewing the literature. Second, the recommendations are based on consensus opinion. There was no method, like no Delphi method, etc., to look at the consensus, how it was generated. And the committee was selected by an informal cascading recruitment process. I mean, I have no questions about the competency of the people who were in the committee, but were they inclusive is the big question. Third, no formal prospective testing of the predictive validity of the various SpO2 F5 thresholds or the non-invasive ARDS subset was done. Fourth, there was possibility of false positives with misclassification because the removal of PEEP and the use of ultrasound is resource-limited settings. And fifth was it really representative of a global definition? There were very few members from resource-limited areas. And also, one needs to understand that a resource-limited country may not necessarily express a person from a resource-limited area within that country. Giving the example of India, I mean, some of us work in the top centers with all the facilities that could be in a resource-rich country, but the resource-limited country spaces would have a very different problem. But that challenge will remain because those in resource-limited areas may not have the wherewithal to have the larger research understanding or the clinical understanding of ARDS. So that challenge will always remain. Thank you.
Thank you very much, Sumit Ray. It was a very comprehensive and a very good lecture. I really appreciated your overview and the way you're passing from one definition to the other. Very helpful. As you know, we will keep the questions at the end. And I'm delighted now to invite Professor Lise Piquilloud from the Lausanne University Hospital. Everyone knows Lise Piquilloud. She is the chair of our acute respiratory failure section, and she has also been very much involved in the guidelines. So, Lise, thank you for enlightening us on outcomes in patients with ARDS.
Good afternoon or good morning, everybody. Thanks a lot for this introduction and thanks for the invitation. It's a great pleasure to speak here today. Then I'm going to discuss the predictors of mortality in our ARDS patients. First of all, as we all know, acute respiratory distress syndrome was first described a long time ago in 1967 as an acute hypoxemic respiratory failure, a severe one, that was associated with poor compliance and with different stimuli. At that time, those patients, of course, were very severe, as today, and they had to be intubated. What is important to understand is that in 1967, mechanical ventilation was used in order to normalize gas exchanges. And that means that high tidal volumes and high pressures were used. And at that time, ARDS mortality was very high, around 70%. Then, in the following years, it appeared more and more evident that mechanical ventilation can induce lung injuries, called ventilator-induced lung injury, and that we should probably be more gentle by delivering mechanical ventilation. And the idea of delivering protective ventilation arrived and was applied. And in parallel, we could observe a huge decrease in ARDS mortality from 70% up to 40% here in 2013. And now it's a bit the same prevalence of mortality, around 40%. Then this lead me to my first take-home message. My first take-home message is that if we deliver protective ventilation to our ARDS patients, which means low tidal volume, between 6 and 8 milliliters by kilo predicted body weight, as said once again in the recent guidelines, which also means using low pressures with a plateau pressure for sure lower than 30 centimeters of water, and which means using enough PEEP to avoid atelectroma, but also not too high PEEP to avoid overdistension. And if we apply this protective ventilation, this is associated with lower mortality in our ARDS patients. We have very interesting data coming from the LungSafe study that was done with the ESICM some years ago. This was a very big observational study with 459 ICUs that participated, 50 countries, 5 continents, and 4 consecutive weeks of data collection. And from this big amount of data, we know that around 10% of the patients admitted in an ICU fulfilled the Berlin ARDS criteria, then had ARDS, and that if we looked at the invasively ventilated patients only, 23.4% of the invasively ventilated patients had ARDS. Of course, the message here is that ARDS is a very prevalent disease in our ICUs. And what about mortality? Then in this big observational study, we find again the number of 40% of mortality if we consider all the ARDS patients together. And interestingly, and even if this probably was expected, it's very important to underline it, the mortality depends on the severity of hypoxemia at time of diagnosis. And you can see here that in case of mild ARDS with a PF ratio lower than 300, but higher than 200, the mortality is 34.3%. In moderate ARDS, the mortality increased to 40.3%. And in severe ARDS, which means PF ratio lower than 100 millimeter of mercury, mortality is very high at 46.1%. We also know from this data that protective ventilation is not really very well applied. In this graph, you can see in the red square, the patients who were ventilated with tidal volume lower than 8 milliliters by kilo predicted body weight and with plateau pressure lower than 30. Then there is still room for improvement. And again, it's very important to underline that protective ventilation is one of the determinants of the survival of our ARDS patients. Then, this is my second take-home message. ARDS mortality is correlated with the severity of hypoxemia at time of diagnosis, as it was clearly demonstrated in the LungSafe data. ARDS is a very heterogeneous syndrome. And when we speak about ARDS, we must underline that there are different etiologies for this syndrome. And in particular, we have the direct lung injuries, mainly pneumonia and aspiration of gastric contents, and all the indirect lung injuries that lead to ARDS. Of course, sepsis of non-pulmonary origin, pancreatitis, burns, trauma, all those other causes of ARDS. And when we speak of heterogeneity of ARDS patients, we also have to consider that different phenotypes, biological phenotypes, have been described. And we have the hyperinflammatory phenotype and the hypoinflammatory phenotype. What is the difference? Then basically the patients with ARDS who have phenotype named number 2 or hyperinflammatory have higher plasma levels of inflammatory biomarkers, more often need the use of vasopressor, have more acidosis, metabolic acidosis, and more often have sepsis. And if we first consider the question of direct versus indirect lung injury and the potential impact of these two different groups or subtypes on mortality. There is an interesting study, a retrospective study, published in 2017, where patients with direct ARDS and indirect ARDS were compared. Interestingly, in this study, patients with direct ARDS had more severe hypoxemia, a higher lung injury score, but were less severe. They had lower SAPS-2 or Apache-2 scores, and they also had fewer non-pulmonary organs failures compared to patients with indirect ARDS. And what about the mortality of these two different groups of ARDS patients? Then, interestingly, the mortality was similar between direct and indirect ARDS. However, very interestingly, the other factors that were associated with mortality were not the same in the two different types of ARDS. As you can see in this table, for direct ARDS of pulmonary origin, the age was associated with mortality. Older patients had increased mortality. The severity of the lung injury was also associated with mortality. And those two factors, age and severity of lung injury, were not associated with mortality in indirect ARDS. For indirect ARDS, the factor that was associated with mortality was only the number of non-pulmonary organ failure. This was also a predictive factor for mortality in direct ARDS. And to underline the point that the predictors of mortality are not the same in those two groups of patients, we have those two graphs that clearly shows that older age is associated with increased mortality in direct ARDS, but not in indirect ARDS. And same thing for the severity of the lung injury score. Regarding the other organ failures, it's interesting to look at these recent data that come from secondary analysis of the LungSafe database. And here we have the impact of having renal failure in addition to ARDS on mortality. And you can see on the left that ARDS patients who did not develop renal failure during ICU stay had a mortality around 30%. Patients who had moderate acute kidney injury during the ICU stay has nearly 50% of hospital mortality, and patients with severe acute kidney injury had a very high mortality of 57.6%. And this one even worse in the right part of this slide for patients who required renal replacement therapy with a very high mortality and an odds ratio for renal replacement therapy around 4 regarding 90-day mortality. Then it's definitely associated with poor outcome. Now, what about the relationship between those hyper or hypoinflammatory phenotypes with mortality? Then in the initial paper that describes the concept of these two phenotypes, we already have data about mortality at 90 days. And we can see that in the two cohorts of patients that were used to derive those two phenotypes, the phenotype 2, the one that was hyperinflammatory, was associated with increased mortality. And interestingly, in this paper, it looks like the way we set PEEP in a phenotype or in the other seems to be associated with mortality. In particular, we can see that if we apply low PEEP to patients with the hyperinflammatory phenotype, we have increased mortality, then suggesting that maybe those patients could require higher PEEP. Of course, this is just association. It's not a prospective study, but it's of interest. And more recently, this is another classification in hypo and hyperinflammatory phenotype. Again, it's based on the LungSafe database, and the authors used a machine learning algorithm to classify patients as either hypo and inflammatory phenotype. And they looked at the survival. And you can see that we find the same message as the one that was found by Caroline Calfee in her initial paper. Patients with the hyperinflammatory phenotypes have reduced survival. And interestingly, in this new paper with another cohort of patients, they again found a correlation or an interaction with the way we set PEEP. And you can see that again, patients with hyperinflammatory phenotypes who were managed with low PEEP had increased mortality. And this was not the case for patients with the hypoinflammatory phenotype. Again, only association, but probably of some interest. When we speak of heterogeneity in ARDS patients, of course, we all know that the potential for recruitment is highly variable between our ARDS patients. And we have different types of patients. In the lower part of the slide, we have patients who can be recruited when we increase the level of PEEP. Recruited, that means that areas that were not opened with low PEEP can be reopened with higher PEEP. In contrast, in the upper part of the slide, we have patients who cannot be recruited even if we use very high PEEP. In this study, high PEEP was 45 centimeters of water during the CT scan to really assess the amount of lung that was recruitable. And if we look a bit more in details, there were 68 patients included in this study. Then 5 and 45 of PEEP was compared, and Gattinoni and collaborators assessed the amount of lung that was potentially recruitable. And we see in the middle that this amount vary a lot between the different patients. And that we can have patients who are nearly non-recruitable. On the right, it's the one with the white circle, whereas other patients can be recruited, and these are patients with the black circles. And what about mortality? Then if we take the 68 patients who were included in this study and we split them into groups, the half of the patients who had the lower recruitability, mortality was 15%. In the other part, the other 50% of patients who were considered as more recruitable, mortality was 41%, which means that mortality was much higher in the patients who were not really recruitable. This study only included a very low number of patients, and the difference in mortality was not statistically significant. However, the trend seems very clear. also something else that is highly variable in an ARDS patient group. This is the dead space. And the dead space can be assessed bedside using the ventilatory ratio. The ventilatory ratio, the formula is written here, and it is the minute ventilation times PaCO2, measured by blood gas analysis, divided by predicted body weight times 100 times 37.5. It's basically a way to assess the efficiency of ventilation. And as you can see here, this ventilatory ratio, which is easy to measure bedside, is well correlated with the physiological dead space measured with complicated techniques. And you can see that if we split the population in quartile according to the ventilatory ratio, this is definitely well correlated with the dead space. And very interestingly, if we look at the mortality of the patients who had a low ventilatory ratio, less than 2, which means not high dead space, they have much lower mortality compared to ARDS patients with a high ventilatory ratio, which means increased dead space. And this is true for all ARDS patients, and this is also true if we look specifically at the patients with moderate ARDS or at the patient with severe ARDS. And interestingly, in the univariate analysis, the odds ratio for high ventilatory ratio is around 2 regarding mortality. And this association between ventilatory ratio and mortality remains in different multivariate analysis, which means that a ventilatory ratio is an independent factor to predict mortality in our ARDS patients. And this comes to my take-home message 3. Some aspects of ARDS heterogeneity are correlated with mortality. Focal and diffuse ARDS, ARDS of pulmonary or non-pulmonary origin have similar mortality, but the other factors associated with mortality are not the same. Hyperinflammatory phenotype has increased mortality. Poor recruitability seems to be associated with increased mortality, and high ventilatory ratio, which means increased dead space, is associated with increased mortality. The final take-home message is we can say that ARDS mortality is high and remains high. ARDS mortality depends partly on non-modifiable factors, direct versus indirect lung injury, hyper versus hypoinflammatory phenotype, potential for recruitability. However, ventilator settings also impact mortality, and protective ventilation is important. And there is some rationale to go to individualized settings when we treat ARDS patients. Maybe should we use high PEEP in hyperinflammatory phenotype? Or maybe should we definitely individualize PEEP to limit dead space and or hyperdistension? This has to be tested prospectively, but this could be promising for the future. Thanks for your attention.
Thank you very much, Professor Piquilloud, for an excellent overview on the predictors of mortality in patients with ARDS. Please keep your questions coming in. We now move on to the next speaker, Professor Massimo Antonelli, and he is he's the director and also the chair of intensive care and anesthesia at the Gemelli University Hospital in Rome, past president of ESICM, also CRT, and also been the past editor of intensive care medicine. He's going to be talking to us about non-invasive ventilation in ARDS. Over to you, Prof. Antonelli.
Thank you, Sheila, for the kind introduction. I'm really honored to contribute to this beautiful webinar with such distinguished speakers. The first thing, this is my conflict of interests. You see, in a way or another, Lise Piquilloud has pointed out how important may be individualized therapies for our patients. But on one hand, if this may be more or less easy when the patient is invasively ventilated, it becomes a different story when the patient is on spontaneous breathing and receiving non-invasive ventilation. Just to give an example that probably happened to most of us worldwide, a patient with a COVID-19 pneumonia had a bilateral infiltrate with a real ARDS, has been moved to the ICU. At that point, the real matter is, should we or should we not start with the NIV trial? Well, if you look at the results of the application of non-invasive ventilation to hypoxemic patients in ARDS, since our initial study at the end of the 80s, you have a very inconsistent results, and also a large variability concerning the interfaces and settings that have been applied. And unfortunately, the conference rep and the expert panel that Dr. Sumit alluded to, indeed was not conclusive at all. And probably some of the suggestions included into this publication were not very useful. Looking at the guidelines, this high degree of uncertainty has been demonstrated by a number, or we are unable to make a recommendation, we suggest no recommendation, and so on. So somehow even frustrating on the idea of the possibility of applying any given non-invasive technique, regardless if it is high-flow nasal oxygen, CPAP, or NIV. But we have to do something, by the way. And we have to remember that during the definition, the birth definition, a specific room is assigned to the use of non-invasive ventilation, especially in mild ARDS. That one is between 300 and 200 OPF. But we have also to consider the beneficial effect of keeping the spontaneous breathing. In this wonderful publication in 2008 has been demonstrated how the patients who were organ donors and were undergoing mechanical ventilation showed an atrophy of the diaphragm muscular fibers within very few hours. So suggesting that the idea of keeping the spontaneous breathing alive may be a good strategy. But on the other hand, it's also true, looking at the experimental work of Takeshi Yoshida, that by inducing the lung injury, the higher and more severe is the lung injury in conjunction with the spontaneous breathing, the higher is the severity of the damage into the lung. But which are the mechanisms by which we may induce a VILI, a ventilatory induced lung injury? And we have to point out that the essential role is the transpulmonary pressure, which is given by the difference between the airway pressure and pleural pressure. Well, under full control, for example, with an airway pressure of 20, the pleural pressure may be -5, and the total transpulmonary pressure will be 25. But what happens when the patient starts to breathe spontaneously, expressing deep swing, that at least the pleural pressure may reach -20. And at that time, the airway pressure, the transpulmonary pressure may achieve dangerous level up to 40. But it's also true that on the other hand, there are patients who respond differently to the application of the pressure support in these circumstances, and they may reduce or are in between the pleural pressure, expressing not injurious pressure. So a number of question marks. But it is absolutely true that as soon as you have a lung damage, starting from the capillary leak, the lung edema, the impaired gas exchanges, and starting having a deep swings, a low CO2, tachypnea, very often we may have an increase of the tidal volume, an increase of the Pendeluft, perpetuating the initial lung injury and deteriorating the lung damage. The importance of Pendeluft has been pointed out more and more, especially when you compare the assisted control mechanical ventilation with spontaneous breathing or without. And you can see here by using the AIT that the difference of the Pendeluft in the various dependent and non-dependent zones are major. And the graphic representation of these differences are shown by the two videos, where the first one represents the dishomogeneity of the lung inflation under spontaneous breathing with a important Pendeluft, and the other graph, the homogeneity that is given by full mechanical control pressure. However, if we look at the first hypothesis on the SILE, there was a close relationship coming from the Kolobov group in the end of the 80s, and where the relationships between PaO2 at the end of hyperventilation period and the hours of ventilation was quite clear. So the higher is the hyperventilation and the prolonged period of persistent of the hyperventilation, the lower may be the PaO2. And looking at the non-invasive ventilation, we know that if we insist in de novo acute respiratory failure with the application of the non-invasive ventilation, the outcome may be worse respect to the other condition. But if this is true in certain context, by applying the non-invasive pressure support, has been shown in this nice publication that this risk remains also when the high flow nasal cannula therapy can be applied, and delay also in this case the intubation and increasing the mortality. The clinical evidence during COVID-19 of self-inflicted lung injury may be represented by the exposure to hypoxemia and the respiratory distress that worsen the lung damage. If you look at the graph on your left, you can see that the increase of driving pressure was proportional to the lower PAFPF below 100 or the increase of respiratory rate above 25 breaths per minute. So two important elements that may occur in determining the worsening of the damage in response of the characteristic of the patient. However, looking at the lung save results that has been mentioned by Professor Piquilloud, and looking at the persistence of the spontaneous breathing for those patients who were ventilated in these large studies and observational studies, and comparing globally to those patients who were ventilated non-invasively to those who were ventilated invasively, there was no significant difference in terms of survival probability. But just stratifying the patients between those who had a PF ratio below 150 to those who had a higher value under the 150, the difference appear evident for those who had indeed a lower lower conditions. In other words, the spontaneous breathing may be safe when the beneficial, when the APF is above 150, but may be dangerous when the APF is below that terms. If we look at the inter-individual variability or in inspiratory effort, we immediately recognize, looking at the esophageal pressure, that when a patient with the acute ARDS is approached by non-invasive pressure support, in these cases, the way in which the patient answers may be very different, expressing the delta esophageal pressure, which is higher or lower depending on the respiratory pattern and the respiratory rate. So this high inter-individual variability is something that we have to keep in mind when by applying non-invasive ventilation. We have to decide if it's appropriate to continue or not. And looking at the early inspiratory effort assessed by esophageal pressure, you can see that looking at the global population, there is a decrease of the delta esophageal pressure when the non-invasive ventilation has been applied. But looking at the distinction between those who failed non-invasive ventilation from those who had a success, indeed the delta esophageal pressure remained more or less the same looking at those who failed respect to those who were successful and had a statistically significant reduction with respect to the baseline on spontaneous breathing without being assisted. But it is also very well known that the moment we apply the non-invasive pressure support characterized by the combination of pressure support and PEEP, the final results in terms of reducing the PDI and esophageal pressure is much higher and prominent. Other point, however, is just making an important distinction between CPAP and pressure support, because these are two different conditions. And indeed, if you look at the delta esophageal pressure, always measured through the esophageal balloon, between the high flow nasal oxygen in spontaneous breathing respect to the CPAP delivered through a helmet or a non-invasive ventilation delivered to the helmet. In all these cases, you may see how the delta esophageal pressure is importantly lower when the combination of pressure support and PEEP has been applied. And on the other hand, the respiratory effort has been also shown as augmented respect to the spontaneous breathing when the helmet CPAP has been applied. But a word of concern has been shown by our group, looking at the increase of the tidal volume when the helmet CPAP and helmet bead were applied in comparison to the high flow nasal oxygen. And this increase of the tidal volume may be injurious and causing and have been associated with a higher respiratory rate and higher tidal volume to the injurious ventilation. I was really happy to show this algorithm from Domenico Luca Greco and Lise Piquilloud that show how could be the wave of approach these patients, looking at de novo hypoxemic respiratory failure and distinguishing between those patients who had a PF above 150 and those who have a PF below this value. In the first case, you may approach this patient with high flow nasal cannula, and probably you may get higher possibilities of being successful. Whilst looking at those who had a more severe condition of the respiratory function, those who had a PF below 150 but low in respiratory effort with esophageal pressure, delta pressure, below 10 centimeter of water, that can be indirectly estimated by a PaCO2 above 35, which means not hyperventilation, not deep inspiratory swing, then you may just approach this patient with high flow nasal oxygen in combination of prone positioning or CPAP, better with the helmet because you can deliver higher PEEP up to
all of you to thank
guideline. So
CPAP indeed can may just approach this patient with high gel pressure is importantly lower when the combination of pressure supported PEEP has been applied. And on the other hand, the respiratory effort has been also shown as augmented respect to the spontaneous breathing when the helmet CPAP has been applied. But a word of concern has been shown by our group, looking at the increase of the tidal volume when the helmet CPAP and helmet bead were applied in comparison to the high flow nasal oxygen. And this increase of the tidal volume may be injurious and causing and have been associated with a higher respiratory rate and higher tidal volume to the injurious ventilation. I was really happy to show this algorithm from Domenico Luca Greco and Lise Piquilloud that show how could be the wave of approach these patients, looking at de novo hypoxemic respiratory failure and distinguishing between those patients who had a PF above 150 and those who have a PF below this value. In the first case, you may approach this patient with high flow nasal cannula, and probably you may get higher possibilities of being successful. Whilst looking at those who had a more severe condition of the respiratory function, those who had a PF below 150 but low in respiratory effort with esophageal pressure, delta pressure below 10 centimeter of water, that can be indirectly estimated by a PaCO2 above 35, which means not hyperventilation, not deep inspiratory swing, then you may just approach this patient with high flow nasal oxygen in combination of prone positioning or CPAP, better with the helmet because you can deliver higher PEEP up to 12 centimeter water or more. But in case of high expiratory effort with a delta esophageal pressure above 10 centimeter water, and once again, looking also the PaCO2, that in this case can be have the tendency to be hypocapnic, and in absence of metabolic acidosis, what we can do, use the pressure support and better with the helmet, simply because you can use a higher level of PEEP, which doesn't necessarily mean that you cannot use the total face mask or a full face mask. In all these situations, the strict clinical monitoring must be applied. But it is intrinsically obvious that the best way to have an estimation of the effort, as can be shown by comparing the PaCO2 and the delta esophageal pressure by using a balloon in esophageal catheter, may be one of the best options to guide our decision and distinguishing phenotyping from the mechanical point of view our patients just at the bedside. One may criticize that this is not a trivial technique, which is also true, but certainly may offer very clear indication. I want to conclude with some take-home messages, with the attempt of giving a message for the individualization, looking at the different mechanical, respiratory mechanic phenotypes. As first, high-flow nasal oxygen can be adopted as a first-line intervention, and non-invasive ventilation or CPAP indeed can represent a real benefit. But indeed, we need to be honest that the data for the moment are inconclusive. And we have, however, to stress how non-invasive ventilation and the CPAP do have different mechanisms of action. And in general, as mentioned in the algorithm that I showed you before, the non-invasive ventilation is more indicated when the inspiratory effort is high, in order to download the respiratory muscles and reduce the inspiratory effort. When we have the above 10 centimeter of water, or PaCO2 is below 35 millimeter of mercury, and the CPAP high flow are better if the effort is low, below 10 centimeter of water, and a PaCO2 is more normal. That in any case, non-invasive ventilation and CPAP may increase the tidal volume in comparison with high-flow nasal cannula, and then we need to apply a strict monitoring in order to avoid the CD. And we do have a number of research that is ongoing for the real non-invasive estimates of the inspiratory effort. Thank you for your attention.
Thank you
very much, Massimo.
Thank you very much, Dr. Antonelli, for an excellent overview on non-invasive ventilation in ARDS and some very crisp take-home message. We have some time for questions. A lot of questions coming in. Over to you, Prof. Azulay.
Thank you, Massimo, for the amazing lecture. And yes, as Sheila just mentioned, we are flooded by questions. I would like to start by asking to Sumit an important question. You reported on the definitions of ARDS, and Lise mentioned the importance of clinical phenotypes. One of the questions is about the focal type of ARDS and on whether we could call ARDS something that is mostly or only affecting one lung.
You're muted.
This is a good question, and this was asked by the committee which defined gave the global definition of ARDS, but they came to the conclusion that unilateral ARDS cannot be, because the conceptualization of ARDS is that it is a inflammatory response with a leaky endothelium, both vascular and alveolar, across the board. So if it is unilateral, that does not fit into our construct of what we think of as ARDS or our syndromic approach to ARDS. So I think at this present moment, after a lot of thought by the committee, and I personally also believe that I don't think unilateral ARDS could be part of be called an ARDS.
Thank you very much, Sumit. Please, Sheila.
Yeah. So the question I want to ask, and either Prof. Piquilloud or Prof. Antonelli can take that. We always talk about protective lung ventilation in ARDS, but should you be applying this also to patients, those who don't have ARDS? Please.
I guess so. This is what we do. In general, even though these are simply hypoxemic patients, and as mentioned by Dr. Sumit, having just a unilateral, I guess that probably if we want to apply non-invasive ventilation or any kind of form, we should be a prudent approach, considering also under this context the best way to go.
Yeah, I perfectly agree. I would answer yes. but maybe with being a bit less strict in patients without ARDS. It's highly probable that the lower the better is not true, and that there is more a U-shape and an optimal range for tidal volume, for driving pressure, for everything, basically.
Great.
Thank you, Lise. There are many questions on outcomes in patients with ARDS, and I would like to group them like a kind of scenario about what to tell to family members, because the questions are about the severity of ARDS based on PF ratio and outcomes, but also when in patients with the sickest hypoxemic patients, when they require ECMO, what should be said about the probability of survival?
That's a very good question. And when I prepare my talk, I thought, but why is it important to define prognostic factors? Then basically not to decide whether we should treat or not, because we can save even the worst patients. It's a matter of proportion. Then I would say that we should say that ARDS is a severe disease, even if not the most severe ARDS we have in front of us, and that there is significant mortality. But I don't think that we should give more details on the predictive factors to the family members, because we are going to treat those patients the best way we can.
I agree with you, Prof. Piquilloud. I want to ask Prof. Antonelli, a lot of questions on the mode of ventilation. Should we always restrict ourselves to volume control ventilation? What about other modes of ventilation for ARDS?
Okay, I see. You mean those patients who are invasively ventilated?
Yes.
You refer that. Okay. You see, this is a good question, and indeed, we don't have really element to say whether the volume control or pressure control are better or the PRV. And there are a number of publications in favor of one or the other. In general, is preferred the volume control for, in my opinion, for a very simple reason, that it allows more easily the respiratory mechanics parameters to be collected and may better guide the choices. But often looking at the pressure control mode that is absolutely efficient is something that needs to shift to the volume control in order to make some measurements in patient on spontaneous breathing. The story changes completely if you want to apply the pressure support in invasive ventilated patients. And you need to know that, of course, even much less than under pressure control, the possibility of having good measurements of the respiratory function are much lower.
Right.
Thank you, Massimo. There is a question for Sumit. No, please, Massimo, carry on.
No. I wanted just to ask the other two colleagues if they agree this position or they do have other ideas.
No, I do agree. 100%.
Yeah, I would absolutely agree. Absolutely.
A question for you, Sumit. It's about the definition of ARDS on what we have on ICU admission as compared to the dynamic aspects, not only of PF ratio, but also on the different elements of clinical phenotypes.
The subphenotypes that have been kind of so I think again this has been considered for a while, that should subphenotypes be part of the definition, put in the definition for ARDS. And though a tremendous amount of work has been done, particularly by Dr. Carolyn Calfee's group, but I think they have been mostly latent class analysis, and it requires a more prospective study to really define these subphenotypes before we can put it into a definition. I think I think we should wait before I think by the next definition we will have enough evidence for that, if we have enough evidence. Dr. Antonelli wanted to say something.
Yeah, I want just to add that it's certainly really valuable, all the work that Caroline Lacaffier has been done. but we have to also to recognize that some of the aspects that characterize the different phenotypes are not always universally available. And often the laboratories do not test for certain parameters. Let's you give an example, interleukin 6, just for mention one of those. And then at the very end, in many different places, the only thing that we can do is just to look at the the respiratory mechanics that can be done by everyone at the bedside, with a lot of limitations, I understand. But we need to find a way that can be applicable everywhere.
So Massimo, are you saying that we could approach clinical phenotypes also by the response to a given ventilatory strategy, like, for example, NIV?
Yeah, that's what I try to show with my presentation, indeed.
Thank you very much.
Yeah, I also agree for that. And we have quite easy way to understand the heterogeneity, I think. I think ventilatory ratio is one. Probably assessing recruitability becomes more and more possible with bedside tools. Not easy to do, but at least available bedside.
Right. I agree with you completely. I want to ask Prof. Piquilloud, setting PEEP in patients with ARDS, invasive ventilation, has always been something that's a question a lot of people ask, and there is the question on this. So what is the ideal way to set PEEP in these patients? What is your recommendation?
Definitely for that, also a matter of balance. We need some PEEP. We are clear with that. This is already in the initial description of ARDS. If we don't use PEEP, we have atelectasis and shunt. But too much PEEP, especially in some patients, those ones who are definitely not recruitable, can lead to overdistension, and overdistension is probably bad for hemodynamics, but also for ventilator-induced lung injury. Then it's definitely a matter of balance and of looking at the patient you have in a given bed, and we cannot find, in my opinion, an universal strategy. It depends on the patient.
Right.
Thank you. Yes, please, Sumit.
Just to add to that, I think titrating. I believe that titrating PEEP is much better than going for a table with a FiO to PF ratio. I think those tables were devised for two reasons. One is for study purposes, and it is devised in Northern America, where most of the ventilatory settings are set by the respiratory therapists, and the physician's involvement is in the initial rounds, and they are not the ones who set the ventilator as much as in Europe or in India. So they need an algorithm to set the PEEP there, which I think is not the correct way to set the PEEP. That's my humble opinion. I think titrating the PEEP based on the bedside at the respiratory mechanics of that individual patient is very important. And studies which look at high versus low PEEP, I think, are asking the wrong question.
Thank you, Sumit. I tried to summarize a number of questions, and I would like to ask the same question to the three of you. And maybe, unless Sheila has another burning question, we will end up with your answers. The question is, well, we moved, and Sumit, your lecture was really good for that. We moved from one definition to the other, incorporating either only clinical things to make it simple, or mechanical things to be really adapted to the reality of ARDS, or sometimes dynamic things. At the same time, mortality has decreased over the years. So do you think that mortality depends on the way we define ARDS?
Okay. Should I take it?
Sure.
Yeah. Okay. So I think it does matter how we define, but it also matters about our pathophysiological understanding of the disease process has over time evolved significantly, and a tremendous amount of work, particularly coming out of Europe. And that has helped us manage the way we manage patients way better than I did about 25 years back when I became an intensivist. So it's not just a definition. Yes, it matters, but more importantly, many of the little additional knowledge that we have gained over a period of time, which has added to the benefits that has happened to ARD in our management of ARDs.
Prof. Antonelli?
Simply that we moved from a very foggy environment where we are looking for an interpretation, a pathophysiological interpretation, in a more and more understanding, many more bricks in the wall, with the, as Sumit say, in this sense, the acquisition of new knowledges is something that is ongoing, and probably better understanding not only the biological patterns, but also the mechanical patterns is making a difference, characterizing much better every individual. In other terms, what we said several times, one size doesn't fit for all. And we need to really individualize, looking at the PEEP, looking at the response, look at PCO2, PF, and so and.
Thank you very much, Massimo. Lise, maybe?
Yes, probably also that there is not true parallelism between the moment that the studies are published with important messages and the moment when we really apply what we've learned in studies. And we can imagine that the progressive decrease in mortality is partly related to the question of using low tidal volumes. Because even if lung safe, we are still not perfect and far from that. Yeah. Then we still have to underline that, I think. And for that, the guidelines, the new guidelines are of major importance, I think.
If I may just ask one last question to all three of you. The guidelines do tell us do A, B, C, whatever. But how far are we from, we all agree that we shouldn't have a one-size-fits-all approach. So how far are we from having an individualized approach to managing ARDS? What's your take on this? Any of you can take this, or all three of you.
I would say that we are convinced that it's the solution, I think. I am convinced, and I think we are convinced. But we need to test it prospectively. We need to find common agreement on what we have to do, how, and then test.
Sumit, what's your take on this?
So I agree with Dr. Piquet. So I also that I think it's not just it's also at the bedside, testing these at the bedside on the individual patient, that titrating every element of what we are going to manage in ARDS at that individual patient. And during COVID, it was also otherwise ARDS too, but COVID was even a learning experience, because some of it behaved like what we usually deal with ARDS, and some things didn't behave exactly as we expected it to. So titrating things at the bedside was very important to treat the patient. And each of the elements in the guidelines titrated to the individual, and what fits that individual is what is most important, I think.
Prof. Antonelli?
I totally agree. I totally agree. In addition to that, I can tell you that probably step by step, we are closer and closer to the capability of individualizing better our therapies. It means that we'll resolve all the problems. I don't think so, because there are a number of issues that are still unresolved. But as Lise said, we need to set up a way and then to validate it in the future, and we'll see. But it takes time. Cannot be done in a night.
Right.
Roma has not been done in a night.
Yeah. Prof. Azile, you want to summarize and
Yeah, I would like to thank the three speakers for all the things we learned today. And of course, we could not approach all the questions. There are a huge number of questions. I remind all of you that the paper on the guidelines is very easy to read. It addresses the 21 questions, the 21 recommendations. So all your questions on tidal volume, PEEP, prone positioning, ECMO, ECHO will be found there. And I can tell you it's very easy. As far as you have read the first part on definitions, it's always the same, and the guidelines are very well highlighted. So please get to there, and you can also see in replay the first webinar that was delivered by the Society on ARDS. I would like to thank all of you, to thank all my colleagues from ISCCM, colleagues and friends, because as you know, we are very close to our Indian colleagues, and we look forward to see you very soon. Please, Sheila.
So excellent three presentations and great discussion. We can go on and on and on, and there's so many questions coming in. But I'd really like to thank ESICM and especially Prof. Azoulay for facilitating this. And it's great to learn from each other and from these presentations. And the ESICM guidelines on ARDS, which is published in Intensive Care Medicine, is a really comprehensive draft. And we recommend that everybody reads it. And a lot of questions that have been asked, you have the answers in this guideline. So thank you very much and have a good evening for the rest of the day.
Thank you.